Last talk of the day is by Nancy Ann.
Okay, so last talk of the day, medical management of meningioma. And you are probably thinking to yourself, this is going to be quite a short talk because there is no FDA-approved medical treatments for meningioma. And you are exactly correct. But I do think there's a lot of interesting things coming down the pipeline. So just wanted to highlight some of those. No disclosures for this talk. And since Dr. Perry gave one of the first talks this morning, and now we are at the end of the session, I just wanted to reiterate the diagnosis of meningioma. It did change slightly with the WHO 2021 updates. The essential diagnostic criteria include classic histopathologic features matching at least one of the meningeal subtypes, or suggestive histopathologic features combined with a biallelic activation of NF2 or other classic drivers of conventional meningioma. And Dr. Theodosopoulos nicely reiterated over here all of the different drivers that we can now see that are associated with different locations of meningioma. Or really fascinating that one of the diagnostic criteria now is suggestive histopathologic features combined with one of the defined DNA methylation classes. So really, again, pushing our field forward now using DNA methylation profiles to define meningioma. Atypicals are WHO grade 2. They have a really high mitotic index, greater than 4 per 10 high power field. We see this in about 20% of cases, and they have to have at least 3 of the 5 soft criteria: sheeting, spontaneous necrosis, macronuclei, small cells or hypercellularity, and then brain invasion. Now, anaplastic meningiomas, they're even more rare, only 1 to 2% of time. These are those that are excessively mitotic, greater than 20 per 10 high power field. They have frank anaplasia. They can look like sarcoma or carcinoma or melanoma-like. And these can be defined by molecular alterations as well. TERT promoter mutation, as well as the new one, which is CDK2A homozygous deletion that can actually define the anaplastic meningioma. So many things have been tried in meningioma, and we have not had success. Hydroxyurea, mifepristone, octreotide, the list goes on, including Avastin. So we've definitely been trying with little success thus far. But the truth is that meningioma really has complex signaling pathways, and there are several different locations that we may be able to target within these signaling pathways that may give us better treatments for meningioma. So we have tyrosine kinase receptors, the RAS, RAF, MAP kinase pathway, mTORC, AKT, PI3 kinase, also the sonic hedgehog pathway can sometimes be activated. So there really is rationale to use targeted therapies in these patients. Now, one of the first case reports that came out looked at a patient with an AKT mutation, and this patient had multiple meningiomas that were just continuously growing until he was placed on an AKT, a selective inhibitor, AZD5363, and all of a sudden the meningioma stabilized, and some of them even got better. So this was really one of the first rationales for the development of targeted therapy towards meningioma. And this is Dr. Brastianos, who we heard from earlier, her study from Alliance looking at targeted therapies meningioma based on genetic characteristics of those tumors. So the 2 arms in the beginning were SMO mutated tumors using mismodegib, and NF2 mutated tumors looking at the FACT inhibitor. And she did a lovely job presenting the FACT arm already at ASCO this year, which was completed enrollment. So these were patients with NF2 mutations. Cohort 1 was progressive grade 1. Cohort 2 was progressive 2 and 3. Both cohorts were treated with the FAK inhibitor. For grade 1 patients, the PFS6 was 83%, which was fantastic. Grade 2 and 3 patients, the PFS was 33%. The conclusions from this study, it had excellent tolerability, resulted in improved progression-free survival for both recurrent and progressive NF2 cohorts, which is really fantastic. This happens to be one of my patients that was one of the grade 1 NF patients. Pre-treatment scan, she was actually going blind. She was placed on this inhibitor. 24 months later, she still had stable disease and preservation of her vision. So really exciting. So because of that, more arms of this study are being put into action. There is going to be a new AKT inhibitor arm for PI3 kinase AKT mutated tumors, as well as something that I'm pretty excited about, a CDK inhibitors for both CDK and NF2 altered tumors. So because we don't have anything and those arms aren't open, we've actually been treating some of our patients off-label with CDK inhibitors. So I just wanted to present this as well. So this is one of my patients with a grade 3 meningioma who happens to have NF2 heterozygous loss, as well as CDK2A2B homozygous loss. multiple recurrences, surgery, proton radiation. I had her on bevacizumab. She lost her vision. Dr. Riley gamma knifed her. Things just kept getting worse, and we wound up doing ablasiclimab. And all of a sudden, the meningioma started to get better, and actually her vision was restored. So really kind of incredible results to see, and really very gratifying to see patients getting better with these targeted therapies. We've tried this in other patients as well, including those with grade 1 disease with NF heterozygous loss, as well as patients in grade 3 disease with the CDK homozygous deletion. This is 2 different examples of patients that I have, a grade 1 and a grade 3. Both had multiply recurrent tumors. Both are doing really, really well on ablasiclimab with stable disease and very little side effects. So more down the pipeline, there's going to be several, I think, CDK inhibitors trials coming, which is really exciting. All right, the other avenue that I'm pretty passionate about is immunotherapy in meningioma. So meningiomas are really interesting. They're not like gliomas. They're not limited by the blood-brain barrier. And so these tumors are much more accessible to the peripheral immune system. There's multiple immune cells and their microenvironment, including CD8 T cells, CD4 T cells, Tregs, macrophages, dendritic cells, microglia. They're all right there. And so we really feel like potentially harnessing the immune system to help fight these tumors may be a successful strategy. We actually know that PD-L1 expressing macrophages, when they infiltrate the meningioma, you have a worse prognosis. And also patients with a higher proportion of tumor infiltrating T cells have shorter burst-free survival. So there are many targets that we can go after for immunotherapy in meningioma, including the PD-1 and PD-L1 inhibitors, as well as some other targets as well, such as CTLA4 and TIM3. But definitely something to look at is these PD-1 and PD-L1 inhibitors in meningioma. All right, so I just wanted to highlight there's multiple immunotherapy trials going on right now for meningioma. At Dana-Farber, they're using Nivo and Ipi. At Rabin Medical Center, they're using pembrolizumab. Avalue is happening at WashU. Mass General also has a pembrolizumab. NCI using nivolumab. And then I would be remiss if we didn't want to talk about the UCSF trial, which is using pembrolizumab in conjunction with stereotactic radiation to help boost that immune response. So I do think if there are people out there that are looking for treatments for meningioma, definitely immunotherapy would be something to consider. And this is one of my patients that we've treated with this protocol, stereotactic radiation plus immunotherapy, multiply recurrent grade 2 meningioma, doing great on this treatment regimen, stable 9 months, maybe even slight improvement. So definitely something that you should stay tuned for the future. So like I said, quick talk on medical management of meningioma, but the take homes it is on the horizon. I think we should all be excited about targeted therapies for meningioma as well as immunotherapy coming down the pipeline. And so with that, I want to thank the team meningioma that we have at UCSF that's really led by Dr. David Riley, who you heard from earlier, really has some incredible basic science work, preclinical work, and is a phenomenal radiation oncologist. Steve Bronstein's my co-PI for the clinical trial, and the rest of the group, and I would be remiss without just mentioning Dr. McDermott, who was with us at UCSF and is now in Miami, but really spearheaded meningioma at UCSF. All right, whirlwind. So it is 3:24. And I would just like to take this moment to thank everyone involved in the planning of this symposium today, especially my co-host Bjorn Schwer. It was amazing to work with you. And then our senior advisors, Dr. Berger and Dr. Chang. We've learned so much from you along the way, and we're so glad that we could do this with you guys today. And then I have to also have a huge shout out to Naomi Hoffer, who was behind the scenes and did all of the planning for this. She's the one that sends you all the emails and all the reminders. She really just did such a phenomenal job. Naomi, we love you. Thank you. Alona, thank you so much for your hard work. And I also wanted to thank every single one of the presenters. You did such a fantastic job, even though we ran over a little bit of time. And also all of the participants that made it here today and got to spend some time with us. Don't forget, you're gonna get a link that allows you to look at these talks again on demand. It'll take us about a week or two to get that sent out to you, but look for it. And also, please, we do value your feedback. So if you have time to fill out the survey, let us know what worked and what didn't. And we look forward to hopefully doing this again sometime in the future and taking your feedback into consideration. So with that, thank you to everyone for the first annual UCSF Brain Tumor Symposium.